But yeah, your eustachian tubes found in your nasopharynx, they are the ones that are connected to the ear. And what's happening, they're not there to drain stuff, because normally there shouldn't be fluid in the ear. If you're sick, then yes, you can get fluid in the ear. But what happens, think about when you go up a really high hill or you're in a plane, what happens to your ears? They pop, and you hear that pop. So what these are for, because when you swallow, you can get it to pop even. What they're for is to stabilize the air pressure in the ear. So when you go way up on a mountain, the pressure out here is greater on you. The pull of gravity is heavier on you. So then in the ear, it's different as far as the pressure. So then it will pop open and equalize. So the reason why with upper respiratory infections, you can then lead to ear infections is because if we've got bacteria in here, it can crawl through that little bitty hole into the ear. And so then you get ear infections along with upper respiratory. So if you go into the doctor and you're like, yeah, you go in, my ears are hurting, and they'll say, well, have you been sneezing? You got a runny nose, and you're like, yeah, I've had a cold. And they're like, okay, you probably have an ear infection, and that's why. Your oral pharynx. So this is where you're going to find your tonsils. So if you go, and look in the very back of your throat, that's your oral pharynx. Is the back of the throat. You have, and palatine tonsils, those are the ones that the big, huge ones in the back of your throat that you'd have removed for a tonsillectomy. So you've got 3 different types of tonsils. And then you've got some laryngeal ones that are sitting at the base of the tongue that you don't see. But the big ones are those palatine tonsils that you see. Going down to the laryngeal pharynx, we have one big structure here. Let me see if we get into it. Yeah, we do. So we've got an epiglottis, we've got the glottis, and then, so here is airway, trachea, and then we've got your esophagus running right back behind it. The thing to know about these 3 passageways, there's only 2 that will have food and air pass through it, or water and air. So the nasopharynx, normally you should not have any food or water going through that. Yes, I know if you swallow, you can get it up through your nose because you start coughing or something, and then it goes up here, and it feels horrible. It gives you a headache because it shouldn't be up there. So normally, food, water will pass through these 2. And it's really that upper portion that water and food will actually go through. And we've got some cool things that are keeping it all going the way it's supposed to go. In the oral pharynx, we also have the uvula, so we like to think of that as like gag reflex. In the very base was those palatine. Tongue, yeah. Laryngeal is way down there. So on the sides here are those big fat palatine tonsils. On the very base where you wouldn't see would be those laryngeal tonsils. Just know palatine are the ones that we do tonsillectomies on. Epiglottis, little piece of cartilage here. It does move and flap over, but the one that tightly closes is going to be down here in the glottis. And the glottis is not an actual structure. There's not anything really there. The glottis is just the opening. So it's just a space in there opening up to the trachea. Your vestibular folds, they are the ones that are the muscles alongside of those cords, not the vocal cords, but they'll close, and that's what's happening when you're swallowing. So when you swallow, the epiglottis will fold down as well as that glottis closes, and it's the vestibular folds that close that. Glottis is just the opening. We'll get into thyroid cartilage. We'll get into esophagus and trachea and how it's built in just a second. So nasopharynx, what is its function? What does it do? Nasopharynx, what does it do? It does provide openings for the eustachian tubes. What structure filters dust, warms and humidifies air, has olfactory receptors? What was that? Yeah, it's that cavern. It's that nasal cavity. That's the one that does all that. Okay, let's get into the lower respiratory system. What time show's break? Okay. Lower respiratory system, yeah, it doesn't look like it contains much, but then we break that all down into all kinds of tiny stuff to make it real nice and easy. Larynx is what you normally think of as your voice box. You do have a big thyroid cartilage sitting there. The thyroid itself sits right over it, kind of like a scarf on it. This is the same thing that you see as your Adam's apple, is the larynx. And that it's that thyroid cartilage, actually, that you see is the Adam's apple. Trachea, so then we'll go through, this would be the pharynx up here. Then we get into the larynx, which is the still upper. Once we get into the trachea, about this portion here, about the level of the lungs, the apex of the lungs, then we start talking that this is lower respiratory. So the trachea is actually included in upper and lower respiratory. So trachea, it's kind of cool because it does have cartilaginous rings. So when you're feeling your trachea, try not to feel around the thyroid cartilage because you have your thyroid gland there and you're not supposed to manipulate it, you're not supposed to palpate it. Don't be messing with it because you can stimulate it to release its hormones. And so it can end up releasing its T3, T4, which could be a bad deal if you release too much. So try not to be manipulating it, but go underneath it and then you can feel your rings of cartilage. So the trachea, its rings of cartilage are kind of cool because they are C-shaped. So right here we've sliced through this person and you can see the little white dots of the cartilage that are C-shaped just like this. And the reason is because on the back side it's open. The trachea itself's not open. It's still got soft tissue. But the reason is because what lies right behind the trachea? Your esophagus. Because you have your airway in front and then right behind you have your esophagus for food. So if you take a big bolus of, a cheeseburger and you really don't chew it up well and it slides down, how does it usually feel? It kind of hurts as you're swallowing, and it's like you can feel it go all the way down, which is not good. You need to chew it up. But you can do that kind of like a snake because that big bolus of food has room to push on that trachea because it's got a soft opening on the back side. If it was all C-shaped, it wouldn't be able to, and it could get stuck and lodged. You definitely don't want that because then you're going to have the Heimlich maneuver for sure. Looking at the lungs themselves, let me make sure I don't get ahead of myself. Yeah, I do. Never mind. I won't talk about it. Okay, so trachea. Once we go through the trachea, then we're going to branch off into your primary bronchi. Looking at these lungs, this would be right side and this would be left side. What do you see different about these two? It's the big, huge branches. So this would be the trunk of the tree, and then these would be the large branches that you would climb on. What do you see different about those two? The right breaks into more pieces. What about the angles of the right and left? Yeah. The right one's more at a vertical angle than the left one. So the right one kind of goes down straight where that left one is kind of branching out a little more horizontal. What issues could you have with that? Or say if I do aspirate food or water, which one is it going to be more likely slide down? It'll slide down this one. It'll slide down the right one because it is more vertical. So if I was placing a patient in a recovery position, so say your buddy got drunk and they could possibly be vomiting, which side would you roll them to? You don't roll them on their back because they could aspirate and choke and die in their sleep. So which side would you roll them to? You would roll them to their left because it's least likely, no, there's still a chance it's going to slide down and they're still going to get food and vomitus in their lungs. But it's least not as likely to happen as if you roll them to the right, it's going to be very easy for that to go down into their lungs. And you can cause aspiration pneumonia, which would be bad. You could then even have food particles lodge in these airways, and you can't do nothing about it. Let's see. So, big deal, and that's why in CPR, when we roll patients and we put them in recovery positions, we put them on the left side. GI stuff, what side did we put them on? Left side, because of how the cecum is shaped. So, if anyone ever asks what side to put them on, you always put them on the left. Safe-wise, we put them on the left. Okay, so, trachea, we branch out into the primary bronchi. And so as that tree gets, the branches get smaller, we move into what are called your secondary bronchi. So primary, secondary. Then you're going to move into even smaller tree branches. And this is your tertiary. So primary would be level 1. Secondary would be level 2. Tertiary would be level 3. So primary, secondary, orange is tertiary. Then you get into really small ones called bronchioles. Remember arterioles. We went from arteries to arterioles. So same thing here. We go from big to little baby ones and we call them bronchioles. Make sure left. So once we go from trachea, primary bronchi, secondary bronchi, tertiary bronchi to bronchioles, then we have what's called, so this would be a bronchiole, then we have what are called alveolar ducts at the very ends, alveolar ducts. And they are finally opening up to what is called the alveoli. So alveolar sac or alveoli are these little bitty grape-filled air sacs. And this is where gas exchange is actually taking place, is at these little sacs. So air is coming through, filling these little bubbles, and then we have capillaries that are completely wrapped around each one of those bubbles. And there's like 30 million alveoli or something crazy. So we've got a lot of air sacs. When you finally notice that your lung functions are decreased, I mean, you've had a lot of these sacs destroyed. So, because we have so many. Same thing with our kidneys. Alveolar sacs, they are made up of epithelium, and it's epithelium. How many layers do you think they are? So when we were thinking about skin and you were thinking about simple and stratified, do you think they're simple or stratified? Why simple then?
Because they can inflate and deflate.
No? Yes. So we can diffuse oxygen and carbon dioxide. We can move particles through these. If we had several layers, that would be hard to do. So with just one layer, you got little spaces in between those layers that are fitting together. So oxygen and carbon dioxide can move in and out of those little holes in between the layers. Same thing with the capillaries that are wrapped all around the alveoli, which is called your endothelium. So it's kind of inside epithelium out here. But endothelium, one layer. It's still epithelial, but it's only one layer. So it can again still have gas exchange. Normally I say like the pinks and teals. So big deal, because this is actually where gas exchange is taking place, is at the alveoli. Nowhere else, just alveoli. let's look at the actual structures of the lungs. You don't have to know the horizontal fissures or the oblique fissures. You don't need to know that. But you do need to know how the lungs are shaped and why they're shaped the way they are. So when you look at your lungs, there are kind of notches. This one you can't see, but kind of on the back side, posterior side, there is a notch. And those are called your hilums. And the reason for them are for the trachea to be able to go in. The trachea, it'd be primary bronchi that are branching into it on both sides. And then you have big, huge arteries going in and veins coming out. So those, and what, bringing stuff back, what arteries are going into the lungs? You should know this right off the heart. Pulmonary arteries, yeah. Remember all that crazy stuff? So it's pulmonary arteries, which are the only arteries that are unoxygenated because they haven't hit the lungs yet. So they're leaving the heart, going into the lungs, and then they're returning to the heart via what? Pulmonary veins. Good. So that all comes back from that cardiac lecture we did so long ago. And also, that hilum kind of gives a place for that heart to snuggle in there. Because again, this is a big, important organ. Right side. The right side is actually bigger. You can see it's got the 3 lobes. It's not longer, though. It's actually shorter than the left side. What would be the cause of that? Why would it be shorter? Kind of squished. And you can even look at the diaphragm. The diaphragm is kind of jacked up on one side. Why is that? What's sitting there? Kidneys are what are called retroperitoneal, so they're sitting back behind that big gut sac. When we talked about the deer slicing them open and this big sac just falls out, then on their back you'll see their kidneys underneath the shiny looking fascia. So what is sitting there? What big organ is sitting there? Yeah, hepat. It's your hepatic, so it's the liver. That is a big, huge organ, kind of tails off over here. And it is. It's pushing up against those lungs, so they're kind of squished up. The very top of the lungs are what are called the apex. You will hear that in nursing when you're doing x-rays and things. When you're assisting patients, and the x-ray tech will say, well, I've got to make sure that board is up high enough on their back to make sure I get the apex of the lungs. Or you'll hear it when they're placing lines, especially PICC lines and central lines that are up here around the subclavian area. They'll say, gosh, I got to make sure I miss that apex. They don't want to puncture a lung trying to put a line in. So apex at the very top, and we've got the base of the lungs on the very bottom. And I told you the right side, for my lefties, this always sucks, just like with the heart. Which side was your tricuspid? The bigger in our gang sides. So right, if I'm right-handed, it's bigger and stronger, so I have 3. Where my left side only had 2. Again, anatomy has been very nice to us because the lungs do the same thing. Just like tricuspid on the right side has 3 cuspids, the left side has 2 for your bicuspid. The right lung has 3 lobes, the left lung only has 2. Thank God they made something easy in all this to remember. So these are very important for our nurses. So when you're doing head-to-toe assessments and you're assessing the respiratory system, and you've had it done to you, when you go in and the nurse or the doctor's listening to you, they go in a systematic spots when they're listening to your lung sounds. So they'll start over here, listen, go over here and listen. What they're doing is listening to the top lobe, comparing it to the other top lobe. Going down, listening, going over here and listening to the middle lobe. Going down and listening to the inferior lobe, and then going over to the left inferior. And how we actually label these and list these are going to be your right upper lobe, left upper lobe, right middle lobe, and right lower lobe. and then left lower lobe. And that's how your nurses and your doctors actually chart those lung sounds. So they may say left lower wheezes noted. So they heard wheezes in this side of the lung. And where at. They'll show you exactly where at they heard them. The lungs do not look perfect like this. It's really hard to see on the right side anteriorly. It's like you only see two lobes. And most of your upper lobes are going to be all front. So when they're listening to you, they're really just listening to upper lobes. When they go on your back and listen posteriorly, that's where they're hitting that middle lobe, and then you can listen to those bottom lobes. Cherish.
Is it true, because I used to have really, really bad asthma as a allergic to cats, and we did now, but when they were looking at my lungs, they actually said that because of it, it can actually age your lungs up a lot.
Well, you're going to have scar tissue. What's happening with asthma, these bronchioles, the small tree branches, the little twigs, they constrict. And then not only do they constrict, but then they can spasm. So when you're trying to pull air in, they are really small. So what does that make you sound like when you're trying to suck air in through a little small tube? Huh? Yeah. And that's why wheezes are really indicative of asthma. You'll hear the, and you may not hear it audibly, like just sitting here. If you hear them audibly, that's bad. But when you put a stethoscope on them and start listening, you can hear them then. And that's still bad.
I just didn't understand when they explained it because they were like all technical terms about it. So
But yeah, you can get a lot of scar tissue. High risk for pneumonia and things. So that's why when they give you things that are called bronchial dilators, so if it constricts with asthma, what do bronchial dilators do? They open it. Yeah, that's what they're for. Your rescue inhalers. Okay. Lungs. The big primary muscle, I think we're going to get into muscles in just a minute, is that diaphragm. So you can see it there, and I'll talk about how it relaxes and contracts. And let me make sure I do. I think we get into muscles. Yeah, okay. Okay, so before I get into linings and things, let's go back to air passage. So when you take a breath in, it's going to move through the nasal cavity, through the pharynx, which is broken up into a nasal pharynx, oral pharynx, and then laryngeal pharynx. Air will then pass through the trachea, through that glottis opening, into and branch off into your primary bronchi, tertiary bronchi, same thing here. Secondary bronchi, tertiary bronchi, bronchioles. Then it'll come through alveolar ducts, the small little openings into your alveoli, where then that oxygen can be transported over to the capillaries in the blood. Finally, we can get some oxygen in the blood, and it can run off to the tissue and dump it off. When it runs off to the tissue and dumps off oxygen, what is it picking up? Carbon dioxide. And it's coming back here and spitting it out, and you're blowing it off. So it'll go through the alveoli, through the alveolar ducts, through the bronchioles, through the tertiary bronchi, the secondary bronchi, primary bronchi, through the trachea, through that pharynx, which is going to start with the laryngeal pharynx here, oral pharynx, nasal pharynx, and we'll blow out the carbon dioxide. So carbon dioxide goes reverse, and oxygen comes through. Now, just like the heart, did we do digestive system? I haven't done digestive system yet. This one's up. Talking about pleural cavities and the membranes. We've at least talked about it with the cardiac system then, because the cardiac does have the same things. Remember when I talked about those visceral feelings? You know, that's like a gut feeling. So try to remember that all of those pleural membranes, if it's a visceral pleura, then it's sitting right on top of the lung. So it's this blue lined here. So that would be a visceral pleura. Lining the inside of that chest cavity or that thoracic cavity would be your pleural or parietal pleura. So parietal pleura is out here. The pleural cavity is just the space in between, colored in red. So visceral pleura, slap right on the lungs. Parietal pleura is outside, lining that cavity. Both of these are secreting what's called a pleural fluid. And what type of consistency does that fluid have? No, not thick. Definitely wouldn't want it thick. Because just like the heart that's beating in that sac, it has visceral pericardium on it, and then you have the pericardial sac, which is parietal pericardium. And so when it's beating and rubbing up against this constantly, you want it slippery, yeah. So it's slippery. Not even like the water consistency. It's slippery. And it should be. Because every time you exhale, those lungs deflate. And then when you inhale, they inflate and rub up against this. Because think about if they were rubbing up against ribs. That would be really rough. And those air sacs are very fragile. So you definitely, they're only one single layer. You definitely don't want them rubbing up against something and breaking. You can get things in this cavity that shouldn't be. So it should be fluid. Nice, slippery, pleural fluid. It's a serious fluid. But if you get things like, say I have pneumonia, and that bacteria not only moves from the lungs, but into that cavity, we produce mucus to trap bacteria and get rid of it. It's your white blood cells that are doing that, going in there and trying to clean up stuff. Well, unfortunately, those white blood cells, they burst and kill themselves and produce mucus. So that mucus can get inside this cavity, and then what consistency does mucus have? It's sticky and thick, yeah. So every time that lung inflates and slaps up against that sticky mucus and then deflates, it's rough. And that's called an empyema, and that's not good. What it does is causes pain. So when you have pneumonia, you could have that, and that's why your chest is hurting on the side or on the front side, and it's because of that. You can have blood. You can have blood fill those spaces. That would be rough and painful as well. And you can have air. You can have a pleural effusion. So if you have air in there, bad deal. And we'll talk about those things that happen with that. Okay. Oh, let me go back. Inhaled food or foreign objects are most likely which side? The right, because it's more vertical. So we roll them on the left. Okay, got to have muscles, not only muscles, but some pressures we'll talk about in a minute, but let's talk about the muscles itself. So looking at these, you have what are called external and internal intercostal muscles. So they're inside the ribs. So internal are closer or medial, and then slapped over them, we have your external, kind of on the outside. Your external, when they pull, they contract. So what happens to this rib cage when you inhale? So those muscles shorten and pull and contract. So if you think about like a big skirt, you pull it up, it kind of pulls it up and out. That's what happens to your rib cage or your thoracic cage when those muscles contract. So they shorten and they bring all this according like bones together and pull them up and out. So that it allows a big space for those lungs to inflate. At that same time, you have a huge muscle the primary muscle, which is this diaphragm here. When it's relaxed, your diaphragm sits like this, like a dome shape. So normally you think of a relaxed muscle would be flat, but it's not. This one is dome shaped. So a lot of people get that mixed up. So it normally will rest just like that, so it pushes up. When these muscles contract and shorten, then that's when that is pulled down. And when it pulls down, then it grabs like it's grabbing the bottom of those lungs and opening them up. At the same time, those ribs are going up and out. So we can inhale. We have lots of muscle contractions occurring when we're taking a breath in. So that's why that is considered the work part of breathing. Taking a breath in is work. Whereas when we exhale, it's called passive. Because we don't have to work hard to breathe out. We'll look at some diseases in a minute that they do have to work hard to push air out. But on exhaling is passive because once we take that breath in, all these muscles have to do is relax. And when they relax, these bones start to fall back down and they push on the lungs to push the air out. The diaphragm that is flat relaxes and pushes up, pushes air out. Everything's relaxing and it's automatically pushing air out doing that. We have other things that are called accessory muscles. So your sternocleidomastoid, as well as your pectoral and your abdominal muscles, those are all considered accessory muscles. So primary would be the diaphragm, and then all those other guys are accessory. Even these intercostals are accessory. Diaphragm is your primary guy. So when you have diseased patients or you have someone that is having difficulty breathing, these muscles are working a little harder to help out breathing. So there is a distinct look to these patients. Number one, the sternocleidomastoid muscles, you can really see them flex as well as they become what are called abdominal breathers, where they're using their stomach muscles to try to help breathe. So it's kind of, and they use their shoulders, they use pectoral, they use everything to try to get air in and push out. You'll see up here that those will actually dent in when they're trying to suck in a deep breath. Those will cave in. And again, those are those sternocleidomastoids. That's a bad deal. They're really struggling to breathe if they're having to pull all of that. If you have what's called an emphysema patient, they're having trouble actually pushing air out. We'll talk about it in just a bit. But if you take their shirt off and they've had emphysema or COPD for years, they kind of get a distinct look to them. They're called what are barrel shaped. So what that means is this way measures the same as this way. And the reason is because they're having to use all these muscles, and you use those muscles for some time, they do get bigger. And so they do build some muscles, which they shouldn't. Their chest gets overinflated because they can't push air out. So their chest gets bigger. So we are what are called a 2-to-1 ratio. You can take 2 of the front side, and there's only 1. So 1-to-2 ratio when you're measuring. That's normal. You should be wider than you are this way. These people aren't. But if you were to take their shirt off and look at them breathe, they will suck in all those little ribs when they're trying to breathe. If you've seen patients or animals dying, they'll suck in on those ribs when they're struggling to breathe. You'll see all those ribs kind of cave in. It's those accessory muscles working hard trying to help that patient continue on. We need to save this because it's going to be a